this presentation is give you an overview of this group of disorders and make it understandable and show you that it's really not that hard. I think people feel that this is a difficult topic, but it's not really that difficult if you look at it in a simplified approach. And also towards the end, if there's time, we'll go through some management of some cases. So the brainstem innervates the orbit. And the orbit is a complicated place. There are a lot of things in a small space. And think about it. The brainstem has to form, the nuclei have to form, they have to send their axons, exit the brainstem, cross a space, and then go to these specific targets in a very small space. It's quite a complicated process, innervating the orbit. And it's amazing that things don't go wrong more often. But when something goes wrong in this process, when there's a disinnervation, we have what we call a congenital cranial dysinnervation disorder. And what typically happens is there's subnormal innervation to something that should have been innervated. And very often there's an aberrant innervation also, with an innervation going someplace where it shouldn't. And this is the concept of congenital cranial dysinnervation disorder, or CCDD. Now, as ophthalmologists, as physicians, we need to be considering all of the cranial nerves, but as ophthalmologists, and particularly those of us who take care of strabismus, there are really 3 cranial nerves that we're concerned about. And historically, there are different forms of strabismus, different forms of concomitant strabismus that have been thought to be different disorders, which we can now unify under the umbrella of congenital cranial dysinnervation disorder. It's a unifying concept. And so there are some strabismus disorders that predominantly involve the abducens nerves. And these are Duane syndrome, Moebius syndrome, horizontal gaze palsy, progressive scoliosis. These conditions, these strabismus conditions that affect horizontal gaze predominantly, we can consider them as form of CCDD that predominantly affects the 6th nerve development. Similarly, congenital fibrosis of the extraocular muscle, congenital ptosis, Marcus gun jaw winking, even monocular elevation deficiency. We can think of these conditions as dysinnervation from the ocular motor nucleus. Congenital fibrosis of the extraocular muscles was named such because it was thought the muscles are fibrotic. It used to be thought to be a primary fibrosis of the muscles, but we now know the fibrosis is secondary to dysinnervation. And congenital ptosis, maybe some of us don't think of that as a CCDD, but it is one. And think about it. The muscle, the levator muscle, is fibrotic and not working. It's a dysinnervation. Marcus gun jaw winking, we see all the time. It's an obvious abnormal synkinesis. Monocular elevation deficiency. Now, this is a mixed bag. Some of these are CCDDs, but others aren't. Some of the MEEDs are isolated fibrosis of the inferior rectus muscle. And when it's that, it's a dysinnervation to the inferior rectus and it's a CCDD. But some of them are supranuclear disorders. And when it's a supranuclear disorder, it's not a CCDD. So MED is a mixed bag. Then moving on to the trochlea, again, things that maybe we don't think about as CCDDs, but we should be. Superior oblique palsy and even Brown syndrome. I mean, superior oblique palsy, very often in congenital superior oblique palsy, you have a floppy tendon. And just like we used to think CFEOM was a primary problem with the muscle, we can understand how if you have a dysinnervation, secondarily, the muscle becomes abnormal, the tendon becomes floppy. And even Brown syndrome, again, it's a fibrosis of the muscle. And you can see how this concept of CCDD unifies things. These different forms of strabismus we used to consider different disorders, we can unify them under the umbrella of CCDD. Now that's a clinical categorization. The way I like to look at CCDDs, and I think it makes it easier to understand them genetically, is to classify them into 3 subtypes. You can have a problem that's affecting projections onto the cranial nerve nuclei or between the cranial nerve nuclei. You can have a problem with formation of the cranial nerve nucleus, or you can have a problem with the axon getting from the cranial nerve nucleus to its target. I like to think about CCDDs in these three broad categories. It helps sort things out. So these are the three genotyped CCDD mechanisms. You can have a problem, supra or internuclear, and these are typically axon. This is an axon crossing problem. There's only actually one CCDD that fits into that category. You can have a problem with the nuclear formation, or you can have a problem infranuclear, that is the axon getting to its target muscle. Now, the supra-intranuclear problem, if you do an MRI, the cranial nerve nuclei are normal because nothing has happened to the cranial nerve nuclei. If you have a nuclear formation problem, of course you do an MRI, the cranial nerve nuclei are abnormal. If you have an infranuclear problem, you might think that the cranial nerves would be normal on the MRI, but in fact, in many of these infranuclear problems, even though the problem is primarily in the axon getting to its target, secondarily, there's degeneration of the nucleus. So in both nuclear problems and infranuclear problems, if you do an MRI, the cranial nerve nuclei that are involved are typically small and atrophic, even though the mechanism for the third mechanism is the axon. Secondarily, there's retrograde deterioration. Just fix this. Okay, good. Now, a word about Duane syndrome. I'm going to be showing different genetic causes of Duane syndrome in this presentation, but I want to stress something that everyone has to remember. When we're talking about the common Duane syndrome that you're going to see in your clinic tomorrow or that you saw in your clinic yesterday, whether it's unilateral Duane syndrome or bilateral Duane syndrome, it's not from gene mutation. Most causes of Duane syndrome, while Duane syndrome is the most common CCDD, 95% of the cases are not from an identifiable gene mutation. The common form of Duane syndrome, even if it's bilateral, is typically not genetic. But there are some genetic forms of Duane syndrome, which I will be highlighting, and you'll see how you can recognize them. So that's the background now. Now let's dive into the CCDDs, and we're going to start with supra or internuclear CCDD, and there's only one CCDD that fits into this category, and this is the condition known as horizontal gaze palsy and progressive scoliosis. This is due to biallelic mutations in the gene ROBO3. ROBO3 is an axon guidance receptor. It is responsible for crossing of pathways in the hindbrain. And when this gene is not functioning, when there's a mutation in this gene, we don't have crossing in the hindbrain. And this causes, as the condition you would suspect from the condition, a horizontal gaze palsy, the developmental abnormality, and also a progressive scoliosis. Here you can see a girl. She has intact vertical gaze. When she looks to the right, there's no horizontal gaze. She looks to the left, there's no horizontal gaze. We see this phenotype. We examine her back. She has scoliosis, which nobody was really aware of or nobody paid attention to. Horizontal gaze palsy with progressive scoliosis. These children can converge, and they often use convergence to look to the side because it's a way to get the eye into adduction. They often have a fine nystagmus. Sometimes they have asynchronous blinking. Sometimes they have strabismus. Unfortunately, 100% of them are going to go on to get a very bad scoliosis. These children are sometimes misdiagnosed as bilateral type 3 Duane syndrome, but I'm going to show you how you can distinguish them from that condition. Here's one of the first girls I ever saw with this condition, and I'll tell you, she really confused me when I first saw her. And I'll tell you why she confused me. Because she regularly, it was practically wired, she substituted convergence for side gaze. Remember, these children, these patients cannot look to the side, and some of them substitute convergence to be able to look to the side. This way they get one eye in adduction and they cross-fix to look to the side. So when this girl looked to the right, this is what she looked like. She converged and she used the adducting eye to look to the side, and looking the other way, she converged. When I first saw this, I was really confused. I eventually realized this was horizontal gaze palsy progressive scoliosis, and sure enough, she's got this horrible scoliosis, again, which was neglected and not really paid attention to. These children also have some fine changes in the brainstem, which we don't have to talk about, in the hindbrain. But it's the ocular phenotype is very, very pathognomonic. Now here's a boy who was referred to me carrying the diagnosis of Duane syndrome type 3 bilaterally, okay? And you can see he had lack of abduction and adduction in both eyes, and that's why he was diagnosed with Duane syndrome. But there's a way you can show that he doesn't have Duane syndrome. And when you really push him, what happens? He converges. He converges to use the adducting eye to cross-fixate. Once again, he's not moving, he's not looking at the pen. You really push him, he converges. You see that convergence? That doesn't happen in type 3 Duane syndrome. That's a sign you're dealing with ROBO3 mutation, and sure enough, he has, again, an undiagnosed scoliosis. His brother was really interesting. His brother had been diagnosed with infantile esotropia and cross-fixation. And again, he actually had ROBO3 mutation. And it was cross-fixating, and he seemed to have abduction deficit, but he actually had horizontal gaze palsy, esotropia, and he was using cross-fixation. At this age, it would have been very difficult to make the diagnosis if we didn't have the other brother who we knew was confirmed, and both of them are confirmed genetically. Let me just show you a video. I don't usually use videos, but I think it's useful here. Let's see if we can get this to work. Look at this girl with horizontal gaze palsy progressive scoliosis. What does she do for looking to the side? She uses convergence. Let's look at it again. Look at this. Watch, she looks to the right, converges. Looks to the left, converges. Typical, very typical. Vertical movements, normal.
So the videos don't show Dr. Khan, huh?
Oh, you didn't see the video?
No, at least me. I'm not sure if other audience can see. Yeah, it's not showing.
No, no.
No?
No. So probably you need to go out of the presentation and present it, and because probably the PowerPoint is not supporting. So I don't know if you can do it. Probably.
Okay. Well, maybe you can do it at the end if we have time. I'll just keep going. So horizontal gaze palsy and progressive scoliosis is it's a fascinating condition. And another interesting thing about these patients, also the cortical spinal tract and the motor tracts don't cross. So if they get a stroke or if they get a trauma to the motor cortex, they don't get a contralateral hemiplegia, they get an ipsilateral hemiplegia. So it's really an interesting miswiring condition. We see this here, we see this in the region, and I have no doubt anybody who's seeing a volume of strabismus in Saudi Arabia is encountering these patients, whether or not they're being diagnosed. So moving on to the next, we talked about internuclear, supranuclear, now nuclear problems. And these are typically mutations in transcription factor genes. There are a few forms of Duane syndrome that are from mutations in transcription factor genes, HOXA1, SAL4, MAFB. These are genes that when mutated cause Duane syndrome. Again, most Duane syndrome that we see is not from gene mutation. There's also a form of congenital fibrosis of the extraocular muscle that's due to a nuclear gene mutation, and that's CFEOM3 from FOX2A mutation. Moebius syndrome, of course, is also a nuclear problem, but typically it's idiopathic. It's very, very rarely is it from gene mutation. So here's a boy with Duane syndrome in the right eye. He's got digital agenesis. He also has renal dysplasia. These are features that make you think something else is going on, and it's actually the SAL4 phenotype. SAL4 is a transcription factor that is responsible for the sixth nerve and for the digits. And when it's mutated, you get this variable expressivity for a condition that's been called Duane radial ray syndrome, sometimes called Okihiro syndrome as well. These also risk for renal problems. Here's a woman with Duane syndrome in both eyes, and she also has deafness. Here's her pedigree. Some individuals have unilateral Duane syndrome. Some individuals don't have hearing loss. This, when you see familial Duane syndrome, especially when it's bilateral, you're more likely dealing with a gene mutation. This patient has the most common gene mutation that causes Duane syndrome. Again, most Duane syndrome is not from gene mutation, but the most common gene mutation that causes Duane syndrome is mutation in this gene MAFB. This is again another transcription factor responsible for formation of the sixth nerve nucleus, and also depending on the mutation, it also causes hearing loss as well. It's responsible for approximately 1% of Duane syndrome cases. Now here's a boy with Duane syndrome in both eyes, deafness, and autism. Same thing with his sister, Duane syndrome in both eyes, deafness. His brother also, Duane syndrome, deafness, and severe autism, unable to take his side pictures. When you see bilateral Duane syndrome and autism, you are most likely dealing with the HOXA1 phenotype. HOXA1 phenotype. HOXA1 is a transcription factor. When it's mutated, it's actually expressed early in embryogenesis, so it causes multiple problems, not only Duane syndrome and deafness, but also cerebrovascular abnormalities and cognitive maldevelopment. Beware of this if you ever have a patient with Duane syndrome and autism. The Duane syndrome, though, is always bilateral in this condition. They need cerebrovascular workup. Now here's a woman with their eyes are fixated in the horizontal plane all the way out. She also has ptosis, she also has ophthalmoplegia, and she also has pupillary abnormalities. This phenotype, this recognizable phenotype, it looks like bilateral third nerve palsy. It's the CFEOM3 phenotype from FOX2A mutation. FOX2A is a transcription factor that is exquisitely responsible for formation of the third and fourth cranial nerves. And when there are FOX2A mutations, it's a recessive disease, you get this characteristic phenotype. These children are sometimes diagnosed as bilateral third nerve palsy. I don't like to use that term because when you say third nerve palsy, that implies that the third nerve was normal before and something happened to it. This is a dysinnervation disorder. It's a developmental disorder. It never formed properly, so it's not proper to call them third nerve palsies. It's a third nerve dysgenesis. And very characteristically, these children use their finger to lift their eyelid when they want to see something. They learn how to do this. They have pupillar abnormalities as well. And very interestingly, they also have a retinal dysfunction. It's the only CCDD that's associated with the retinal dysfunction, something about FOX2A that is affecting the innervation of the retina as well. Again, FOX2A is responsible for formation of the third and fourth cranial nerves. It's thought that it's responsible for something in the ciliary ganglion also, which is responsible for the abnormal pupils that these patients have as well. Now here's a girl with esotropia and bilateral inability to abduct. When you look at her, she also has facial diplegia, that is, she has bilateral facial palsy. She has bilateral facial palsy, bilateral sixth nerve dysgenesis. She has Moebius syndrome. And Moebius syndrome is definitely a CCDD, but the vast majority of cases are idiopathic. Very, very rarely there are some genes that have been associated with Moebius syndrome, but that's the exception. The rule is it's idiopathic. and it's often associated with other congenital abnormalities as well. Okay, we've covered supranuclear, we've covered nuclear. Now we're going to infranuclear, and we're talking about the axon and the synapse, problems in axon and synapse formation. So here we have another Duane syndrome phenotype. This one is due to a problem in the axon getting to its target as opposed to a primary problem, the nucleus forming. We have classic CFEOM and CFEOM type 3. And we have some other rare conditions that I'll just mention briefly. So here's a patient with bilateral Duane syndrome. And you know, there's nothing you can tell by looking at his phenotype, but he happens to have mutations in CHN1. CHN1 is responsible for axon guidance. A mutation in this gene causes miswiring. Again, it's an axon level problem. These patients have a higher incidence of bilateral Duane syndrome, and they often have vertical abnormalities as well. So if you see a patient with bilateral or vertical abnormalities, you may be dealing with CHN1 mutation. We now know that also CHN1 mutation can cause vertical phenotypes like monocular elevation deficiency. So it's not only Duane syndrome that this axon guidance gene causes. And here you can see a nice diagram of the axon showing you CHN1 is here. It's responsible for helping there's a growth cone. There are factors here that guide the axon when it's forming. And this is one of the receptors that helps guide the axon to get where it's going. And this is what gets mutated in CHN1 mutations. Now here's a boy. The eyes are infraducted. He's got ptosis. You can see that he can't lift the eyes up. And this is just stopping the frontalis. He's got ptosis. This patient also, when the patient tries to look up, the eyes adduct. This child has the classic phenotype of congenital fibrosis of the extraocular muscles type 1. This is from KIF21A mutation. KIF21A is a gene that transports important substances across the axon. And when it's mutated, although it's expressed all over the body, you get this unique phenotype in the orbit where the superior division of the oculomotor nerve is miswired, dysgenic, and they have hypotropia, large angle exotropia, ptosis, ophthalmoplegia, and very characteristically, when they try to look up, the eyes typically adduct. It's a very characteristic feature. CFEOM1 is autosomal dominant. It's not more common in this region than anywhere else, but it's the most common form of CFEOM in the world. Very interestingly, all of the patients all over the world, most of them have the same mutation, or at least in the same residue, as did the Saudi family. It's a hotspot for mutation. When you see this phenotype, you're almost always dealing with mutation in this gene, not only mutation in this gene, KIF21A, but in this particular spot. Now, KIF21A mutation does not cause CFEOM1. It can cause other phenotypes. CFEOM1, again, is defined as infraducted eyes that cannot reach the midline with exotropia, ptosis, ophthalmoplegia, and very often adduction on attempted upgaze. That's the phenotype of CFEOM1. CFEOM that doesn't fit into that category is called CFM03. And here's a girl, you can see here, when she has ptosis, she has esotropia, she has ophthalmoplegia, and look what happens when she tries to look up. Can you see the eye is adducting? The right eye is adducting, very characteristic of KIF21A mutation, even if it's not CFEOM1. And this girl has other forms of aberrant innervation. We're not going to go through it. I just wanted to show you how this elevation, during elevation, this convergence during elevation, very characteristic of KIF21A mutation. I'll skip the video since they weren't working. And again, KIF21A, you see this little like car here, it goes on the microtubule and it carries materials down the axon. That's what KIF21A does, and that's what's mutated in congenital fibrosis type 1. Now, this gentleman was diagnosed with Moebius syndrome, but that's not what he has. Because although he has bilateral facial diplegia, although he has bilateral facial weakness, Moebius syndrome patients are esotropic or orthotropic. They're not exotropic. Exotropia is not part of Moebius syndrome. This boy also has ptosis. He actually has the phenotype of CFEOM3, actually a specific TUBB3 mutation. TUBB3 is a gene that codes for the microtubule that KIF21A rides over. And when we have TUBB3 mutations, we get variable CFEOM3. But some mutations are specific for specific phenotypes. And actually, this boy has a phenotype specific for a specific TUBB3 mutation. Now, whenever you have a patient who has a child who has strabismus and facial weakness, don't jump to the diagnosis of CFEOM. We have to rule out the possibility of a neuromuscular disease or myasthenia or even mitochondrial disease. We have to worry about that whenever you have strabismus and weakness in other parts of the body. But TUBB3 mutations, heterozygous TUBB3 mutations, cause CFEOM with muscle weakness and intellectual disability. So this is one of the phenotypes that we see. Again, here is the axon. KIF21A carries materials down the axon like I showed you before. It walks on the microtubule, and TUBB3 codes for the microtubule. So KIF21A cannot walk. And that's what happens with TUBB3 mutations. It causes a variable CFEOM phenotype, and also they have neurological abnormalities as well. I will skip the video because it wasn't working. Now, take a look at this family, and this is something relevant to all of us, and sometimes we don't have the time to look into it, but the only way we're going to understand more about these things is if we pay attention. This girl has ptosis, okay? But not only does she have ptosis, when she abducts, the ptosis resolves. She has an abnormal synkinesis between the 6th nerve nucleus and the levator. Her brother has the same thing bilaterally though, congenital ptosis with lid elevation with ipsilateral abduction. It's a 6th nerve lid dyskinesis. The older sister, who's not pictured here, just had isolated bilateral ptosis. She didn't have any abnormal synkinesis. But this child had Duane syndrome in the right eye, classic Duane syndrome. So all 4 of these children with different phenotypes actually have the same disease. It's variable expressivity of the same disease. These are all different phenotypes of CCDD. And conditions we might have before thought about as separate, we really have to unify them as CCDD. And it's hard to do that when there's 1 or 2, recognize that this is going on when there's 1 or 2 people affected. But when you have a large family like this, you can start to see patterns. As a matter of fact, we studied this family and we found the mutation causing this phenotype. It's something responsible for ocular motor nerve innervation. And it just shows you the variable expressivity we can see with CCDDs. Here's another family. This patient has a really bizarre phenotype. I don't even know how to describe it here. He's looking straight ahead. His left eye is way up. When he looks to the right, the left eye goes down. When he looks to the left, I don't know where this eye is going. It's a really abnormal dysgenesis synkinesis. And he also has arthrogryposis. This is from mutation in this gene. Again, it's a rare phenotype. ECEL1 mutations cause arthrogryposis and variable CCDD. It's responsible for synapse formation. And here's his sister. His sister has unilateral ptosis and a V pattern exotropia. V pattern exotropia can be a CCDD when you're looking up, the lateral rectus is inappropriately firing. It can be a form of CCDD. And she again has the arthrogryposis. And another sister has Duane syndrome and ptosis, and also the arthrogryposis. Again, you'd have called these different diseases before, the strabismus phenotypes, but they're actually different expression of abnormal synkinesis, of abnormal innervation, CCDD. And you know, this gene has been described. ECL1 mutations cause arthrogryposis with CCDD. This is the final one I want to show you, gene mutation. This is a really interesting family. 3 affected siblings. One boy has unilateral congenital ptosis. The sister has bilateral congenital ptosis. And now the brother. Now the brother has Duane syndrome type 1 in the left eye, okay? That's why he has a left face turn, because he cannot abduct that left eye well. But what he has in the right eye, he has a weird form of Duane syndrome, which is sometimes called Duane syndrome type 4, Duane syndrome with synergistic divergence. And when he tries to look to the left, and he can't look to the left because he's got Duane syndrome type 1 in the left eye, the right eye abducts further because he has synergistic divergence in the right eye. And look at these 3 different phenotypes in these 3 siblings, all caused by biallelic mutation in collagen 25A1. Collagen 25A1 interacts with TUBB3, with the tubulins. So it affects that scaffolding that KIF21A walks over. Again, see how we can have different phenotypes within the same family. This is a rare condition, but just showing you how the concept of CCDD unifies what we thought to be separate conditions. We'll skip the video. And instead, I'll summarize what I've been saying. Phenotypically, CCDDs can be broadly categorized as primarily horizontal. That's involving the 6th nerve, and that we're talking about Duane syndrome, Moebius, horizontal gaze palsy, progressive scoliosis. They can be primarily vertical, and we're talking about CFEOM, congenital ptosis, or superior oblique palsy or Brown syndrome. Or they can have variable ophthalmoplegia, and a characteristic of CCDDs is variable ophthalmoplegia with aberrant innervations. Mechanistically, we can think of CCDDs as supra or infranuclear, nuclear or infranuclear, and many of them have gene mutations identified. The major exception being the most common CCDD, that is Duane syndrome. Most Duane syndrome does not have gene mutation. We should consider the possibility of CCDD when we encounter a patient with apparent orbital fibrosis or dysinnervation, or multiple different strabismus or ptosis phenotypes in the same family. This is when you should think that there's an underlying CCDD going on. Now, I didn't talk about surgery, but we can talk about that now in the last few minutes. Strabismus surgery is not standard recess resect for these patients. You have to have a specific goal, and you have to be very careful because you're dealing with muscles that are subinnervated, and you have this problem of the abnormal synkinesis where you can get very strange results, unexpected results, when you think you're just doing the right thing. So I think we have some time, so I'll go through some cases.
Yes, please.
Yeah.
Yes, please.
So I just wonder, you know, if anybody wants to say, how would to manage a child with CFEOM1? Let me see. Is there a chat? Is there anybody want to say in the chat how they would manage a patient like this? Let me see. Well, let me just say, these patients, CFEOM1, if you have a CFEOM1 patient, it is very difficult to overcorrect them vertically. And in these patients, I've learned you have to be very aggressive. And what I typically do now in these patients, well, first of all, it's important to recognize this. Unfortunately, some of these patients are just thought to have congenital ptosis, and it's not recognized that they have the CFEOM. So, you know, those colleagues who do ptosis surgery, I hope, you know, have to be very aware of the CFEOM phenotype, because obviously if you had a child with regular congenital ptosis, you'll have this kind of a presentation. But if CFEOM1, and from this picture, you can't tell the child has CFEOM1. But when we examine her, we have to look at the motility, and we see the eyes cannot supraduct. And if a patient like this has ptosis surgery, without recognizing the eyes don't supraduct, it's a disaster, because then they'll just get horrible exposure keratopathy, and there'll be no difference with the abnormal head position. So once we do a motility exam, we recognize there's CFEOM1. What we have to do before we address the ptosis surgeries, we have to get the eyes up, because lifting the lids without getting the eyes up is just doing this child a disservice. Now, you can do that separately, or you can do it at the same time as you're doing the strabismus surgery. But if you're doing it at the same time you're doing the strabismus surgery, you have to be very careful with the ptosis surgery. You have to be conservative, because you don't want a mismatch between how high the lid is and how high the eye is, because right now, those low lids are protecting the low eyes. And if you upset that balance in the wrong way, you're going to get bad exposure keratopathy. So every child who has congenital ptosis has to be carefully looked at to make sure they don't have elevation deficiency, and specifically CFEOM1. For me personally, I've just gotten more aggressive with time because I've seen so many undercorrections, and I would attach the inferior rectus to the orbital rim, and even do superior oblique tenectomy at the same time. And with an oculoplastic colleague, consider doing guarded lid elevation. So, you know, for this patient, we did inferior rectus inactivation, that is suturing it to the orbital rim. Superior oblique tenectomies, if you're shy, maybe you don't want to do that. I'm not shy anymore. If I have a real severe case, I'll do that. And, you know, you can get a decent result with this. Of course, the goal is treating the abnormal head position, not the ocular movement. Sometimes when you do this, you get a really large exotropia afterwards. You have to always be prepared for that, and tell that to the family beforehand. These families always have to be prepared for multiple surgeries. Okay, so that's one. So here's a patient with CFEOM2. Now, CFEOM1 is defined by infraducted eyes. They can't get to midline. They're exotropic, they're hypotropic. They have typically this convergence on upgaze, which I had on a video, but you'll have to just take my word for it. And we saw it in the pictures as well. In CFEOM2, this is another defined phenotype. They have huge exotropia, much bigger than CFEOM1. It's in the horizontal plane. They have ptosis, they have ophthalmoplegia, they have pupillary abnormalities. This child has CFEOM2. How do we manage this patient? Again, the standard recess resect, the standard tables, leave them in the other room. Don't bring them to the operating room. They don't work in these cases. If you have a real CFEOM2, I mean, if it's a real one, you know, these medial rectus muscles are sometimes, they're not muscles, they're like tissue paper. It really varies according to the case. But in general, don't assume that you have muscles there. Very often you just have like fibrotic tissue. The point is, you just have to realize you can't get away with recess resect here. And there are different approaches that have been described. What did I do for this case? Let's see. We did I just cut off the lateral rectus. I just disinserted the lateral rectus in this patient and sutured it to the wall, I think. Yeah, sutured it to the lateral, did a maximal lateral rectus resection and just let it go back in this particular case, and then used a suture to fix the globe nasally to the periosteum nasally. Now, like there it is, and there's the suture fixating the globe periosteally and leaving it there. Now, that's not the only approach for this. There are other approaches. People have described taking the lateral rectus and splitting it and bringing it nasally. I think that's an interesting idea. I haven't done it in one of these cases. It might be difficult to do depending on how tight that lateral rectus is, but it's an interesting thought. The major concept is you can't do standard strabismus surgery. If you're going to do standard strabismus surgery, you're wasting your time. And so here's this patient, and this is her. You can see after that the eye is somewhat straight. The problem is with these sutures, they do tend to fade with time. It's not a perfect solution, but the key concept is you have to do something extreme. You can't do standard recess resect in these CFEOM3 cases. Now here's a woman with synergistic divergence. When she looks to the right, this left eye goes out more. She's got an XT with synergistic divergence. She looks to the right, the left eye abducts further. What do we do with a case like this? Once again, your recess resect is not going to help you here, because if you do recess resect, you're not doing anything for that aberrant innervation. She's still going to have aberrant abduction when she tries to adduct the eye. Again, this is another situation where you could think about taking the lateral rectus, splitting it, and bringing it medially. I didn't do that for this patient. For this patient, the way I looked at it is that lateral rectus is misbehaving. It's working when it shouldn't be working. So I want to take it out of commission. So basically what we did was we deactivated the lateral rectus, suturing it to the periosteum, take it out of the picture, and she had a viable medial rectus, and we just did a maximum huge medial rectus resection, and we got her eye in a decent position, and she no longer had that aberrant movement. It's not the only approach, but the point here is we've got a misbehaving muscle and we have to deal with it somehow. And if we just did recess resect, we're not dealing with the misbehaving muscle. This is a video, so I'm gonna skip those videos. I'll just go to this last case. You know, this is a case of Duane syndrome, and you know, typical Duane syndrome, who has a minimal face turn and didn't really need strabismus surgery, but unfortunately it was seen by someone else and had a huge medial rectus recession. I don't know if that person didn't recognize that this girl had Duane syndrome. And this is the point where we have to recognize these CCDDs before we do strabismus surgery, because if we don't recognize them, we get bizarre results, terrible results. This girl has co-contraction when she tries to adduct the left eye, and she has a small esotropia. If you do a large medial rectus recession in this eye, and put this eye into an exotropic position, when she tries to straighten that eye, the medial rectus is weakened because you've recessed it, but the lateral rectus is still working and it's still firing inappropriately when she tries to adduct. So what happens is if you do a large medial rectus recession in a patient with esotropic Duane syndrome and co-contraction, the drive to adduct is going to translate into a large abduction, and you get a large overcorrection. And that's exactly what happened in her. she had a large medial rectus recession, and because it's a Duane syndrome eye, she has a huge opposite face turn, and she cannot adduct this eye because when she tries to adduct, the medial rectus is weak, the lateral rectus is still there, still co-contracting and not letting this eye go in. Even in the straight ahead position, it's out. And this is a big no-no for Duane syndrome. We don't do big medial rectus recession in Duane syndrome when there's significant co-contraction. So for this girl, you know, it's a bad situation. Really, the only solution for her, you could consider bringing the medial rectus back up, but it's not that easy to do that because the medial rectus is tight and fibrotic, and it's attached to orbital tissue. For her, for this situation, I just recessed the lateral rectus, but that's going to cause her ophthalmoplegia, but we have no choice because we can't leave her like this. And, you know, here she is after lateral rectus recession. So I'm going to stop there. I've gone through the genetics of CCDDs. I've gone through the concept of CCDDs, how I think about them. I've gone through a couple of cases. I had some videos, but it's not essential to show them. And that's what I have. If there are any questions. Thanks for allowing me to present this material.
Well, thank you, Dr. Khan. Thank you for presenting to us your experience. I'm sure it took many years to gain all of this huge knowledge. So, Doctor, there is a question. Why did you perform superior oblique tenectomy for congenital fibrosis type 1?
Okay. These patients with congenital fibrosis type 1, if it's a classic congenital fibrosis type 1, they have a large A-pattern exotropia. And they have a hypotropia that is very difficult to treat and very difficult to overcorrect. So, as I mentioned, you know, sometimes when you do inferior rectus recession for these patients, or inferior rectus inactivation, and you release the eyes, the inferior rectus muscles are adductors. And it's not uncommon that these patients get a large exotropia as the eyes go up. And the eyes don't go up fully. So to get
Dr. Romani is up for when it has a technical problem. Other questions?
Thank you, Dr. Sisma. Anyone has a question? I think the topic is very difficult, that's why.
Are people seeing horizontal gaze palsy and progressive scoliosis?
You mean in their practice?
Have you seen it or no?
Well, I'm afraid even if I see it, maybe I will not recognize it in the way
I've seen so many cases. The thing is, you know, they can come to ophthalmologists when they're young, and then they get their scoliosis and they might go somewhere else.
Yeah.
But I've seen a lot. I've been surprised how many cases I've seen of it.
Okay, here's a question. Is the secondary muscle fibrosis progressive in early childhood, or it's fixed since birth?
Well, if you have a CCDD, a congenital cranial dysinnervation disorder, this is a developmental problem, and the fibrosis is secondary the abnormal innervation. And you know, there's something that I want to highlight that probably people were not thinking about. Congenital ptosis is a CCDD. It is not, you know, it doesn't make sense that you just have one muscle that becomes fibrotic congenitally. It makes much more sense, especially in the context of CCDDs and what we understand now, that the problem is innervational. So many of these situations where we have a fibrotic muscle Brown syndrome, Duane syndrome, congenital ptosis. Rather than being a primary problem with the muscle, it's a problem with innervation during development that leads to that fibrosis. Now, if a child has an acquired strabismus and they had normal eye muscles and they have an acquired strabismus, when an eye is in an abnormal position, when an eye is in a strabismic position, the muscle that is contracted, the muscle that is scrunched up from the strabismus becomes fibrotic. But it's different. It's not the same as these muscles from dysinnervation. It's not the same type of fibrosis. So I think I'm answering the question. In the CCDDs, the fibrosis is there from birth that happened during development, but any patient who has an acquired strabismus, a normal muscle will become fibrotic. It's scrunched up because of the strabismus.
Okay. There's a question, what about the problem of cheese wiring of sutures for congenital fibrosis type 2?
It's a problem.
It's a problem.
Yeah. You mean cheese? Do you mean? I think you mean cheese wiring. If you're using a suture to fixate the globe nasally, well, you have to be very careful about suturing the globe, not to cheese wire through. But even if you successfully do it, I have to say with time, it's going to come back. And that's what I know now from experience. So, it's a difficult problem. The suture is not really a good long-term solution for putting the eye in that position. I like the idea of splitting the lateral rectus and putting it nasally, although it can be difficult. Yeah, or there are people who use wires and plates, like orbital plates and wires, to treat things like this.
Okay.
I agree with the comment that using the suture to fix the eye in is not a good long-term solution.
Yeah.
I've learned that with experience.
Well, here's an interesting question from one of our retina colleague. Is the retinal dysfunction of congenital fibrosis type 2 also related to the dysinnervation, or just another mechanism or coincidence with each other, or what?
Well, I have to say that I think it's related to the dysinnervation. Many of these conditions are associated with dysinnervation more than the problem itself. For example, Duane syndrome is classically a dysinnervation of the lateral rectus from the sixth nerve nucleus, with medial rectus compensating. And that's how we think about it. But very often there are other dysinnervations that maybe we don't pick up or pay attention to that accompany it. One classic example is if you go to your Duane syndrome patients and ask all of them if they start tearing when they're eating, you are going to find a significant proportion of them, when they're eating tasty food, something they really like, their eye starts tearing. They don't talk about it because they're embarrassed. But it's another dysinnervation that occurs. And most of these CCDDs, although they seem to be isolated strabismus phenotypes, a particular thing, they are associated with other dysinnervations. And as CFEOM3, I can't tell you why the retinal dysfunction is happening. It's definitely there, though. It's reproducible. But we assume it's related to the dysinnervation. When you knock out FOX2A, and the third nerve and the third and fourth cranial nerves don't form in the brainstem, the resulting cascade of dysinnervation includes affecting the retina somehow, that it doesn't function properly.
Okay. So here's a question. How do you explain the resolution of some cases of Brown syndrome if it was a CCDD?
Well, definitely not all Brown syndrome is CCDD. Some Brown syndrome is CCDD. There are many causes for Brown syndrome. We talk about Brown syndrome like it's one disease, but it's not one disease. It's different pathologies, and there are some patients who get inflammation in the trochlea, and that causes Brown syndrome. There are some patients who just have an anatomical abnormality where the diameter, the distance between the orbit where the trochlea is and the eye is in such a way that it's causing Brown syndrome. And as the patient grows and the anterior posterior diameter increases, it can move again and the Brown syndrome resolves. But there are also some patients where it's in a dysinnervation and the tendon is very fibrotic. So not all cases of Brown syndrome are CCDD, but some of them are. Same thing with monocular elevation deficiency. Not all of them are CCDD, but some of them are.
Okay, two more questions. Can superior rectus transposition improve the abduction in patient with EZO-Duane?
Yeah, that's a huge topic. It doesn't actually include, it's more like a rubber band. You move the superior rectus there, and there's a tone there, and it passively pulls the eye over. So when the medial rectus relaxes, that passive tone pulls the eye. So it's not a true abduction force, but it can increase the range of motion. But you have to be very careful about that, because if you have a patient with significant, again, you have, each of these patients are individual, they're very different. And if you have a Duane syndrome that's more like a sixth nerve palsy that does not have so much co-contraction, and it doesn't have aberrant innervation to the superior rectus, you can do that and you'll get a good result. But if you have a patient who has significant co-contraction, significant aberrant innervation, you should stay away from a transposition of the superior rectus. So the answer of the question is, it can improve the passive abduction in a patient that doesn't have significant abnormal innervation, co-contraction.
Yeah. Last question is there characteristic, okay, so there are two questions. Could congenital fibrosis of extraocular motility type 3 present with a picture like type 2?
It's theoretically possible, but practically no. I mean, CFEOM3, I've never seen a patient, you know, basically what's happening is in CFEOM3, there's a problem with the tubulin, microtubule, or kinesin, and it's affecting muscles kind of randomly. But CFEOM2 is a very specific phenotype, and it's very, very unlikely that that would happen. So I would say it would be very unexpected. I would not expect that to happen.
Okay. One of our colleagues, she's asking about keratoconus with CCDD. She saw two patients having both. Is there any correlation you heard of, or you think it's a coincidence?
I think it's a coincidence. We see a lot of patients with more than one disease. There's no relationship between CCDD and keratoconus.
Okay.
Yeah.
Okay. Is there a characteristic retinal picture for dysfunction? For dysfunction in type 2? No,
it's just that when we do electroretinography in these patients, the readings are subnormal. And also, they have subnormal vision that cannot be explained by amblyopia. You know, patients with exotropia, it's very, how did we first start realizing that these patients had retinal dysfunction? Actually, the retinas looked pretty normal. They had poor vision. Patients with exotropia shouldn't have poor vision. And if they do have poor vision, it should be in one eye, it shouldn't be in both eyes. But we were seeing patients with CFEOM2 with poor vision in both eyes, not attributable to refractive error. That's when we think that maybe there's something else going on. And that's when we started doing electrophysiology and we found these abnormalities. They're not visible. The retina looks normal, but they have subnormal vision that cannot be explained by amblyopia or refractive error. And when we do electrophysiology, we do find there's a retinal dysfunction.
Okay. So we have a question from from Dr. Sahar, our great radiologist. She says that not all cases of abnormal innervation show abnormalities on imaging. So why we should image them?
I don't say we should image them.
Okay.
I don't image my patients with CCDD. And actually that brings up a great point. And I'm glad this point has been brought up. I see many children with CCDDs getting unnecessary neuroimaging. I think it's very interesting to do the neuroimaging to see the anatomical findings, but for clinical management, when you have a child, I see these children, sometimes they're thought maybe they have a neurological problem, maybe they think they have a brain tumor, they think they have bilateral third nerve palsy, they have to do neuroimaging to rule out a mass lesion. This is the importance, one of the important points of CCDD. We have to recognize these patients because it's equally important to recognize when we don't need to do neuroimaging for children. Neuroimaging for a child with a classic KIF21A phenotype, classic CFEOM3, no way, we should never do it. It's unnecessary. But if you're not familiar with that phenotype and you see that, maybe people will do neuroimaging because they're afraid there's a brain tumor. Same thing with CFEOM2. That very often gets labeled as bilateral third nerve palsy, needs a neurological workup. No, it doesn't. If you have the classic phenotype, you know you're dealing with FOX2A mutation, you know it's restricted to a malformation in the third and fourth cranial nerves and nothing else. So I don't do neuroimaging on these patients. Now the exception is if you have a patient with CFEOM and any kind of muscle weakness or facial palsy. Now there I'm worried because while it could be CFEOM3 from TUBB3 mutation, it's also possible it could be myasthenia, it could be a myopathy, it could be a mitochondrial disease. So when you have global muscle dysfunction, you know, outside of the extraocular muscles, that needs a workup. Not necessarily an MRI, it's more of a workup for myasthenia and for myopathy and mitochondrial disease. But that's a setting that needs a workup. But MRI, I don't do neuroimaging for these patients at all. I've just showed you neuroimaging from some of the studies that were done.
Even imaging of the orbit, right?
No, we don't need, not if we have a classic phenotype. I mean, now if you don't understand, if something is acquired, that's a different story. But if it's congenital, the child is otherwise healthy and you recognize the phenotype, it fits into one of these categories. There's no reason to do imaging.
So I think by that question we conclude. Thank you so much, Dr. Arif Khan. It was great to talk and I'm sure everyone got benefit of it. And hopefully we'll meet in future.
Nice to see you. Thanks for having me and great to be with everyone, at least on the internet.
Yeah.
Not on person.
Okay. Bye-bye.
Okay, bye. Thank you.
Welcome.